is Dr. Gigi Chen, who received her MD from the University of California at Irvine and completed her residency in internal medicine and her fellowship in hematology and oncology at UC Davis. She's board certified in internal medicine, medical oncology, and hematology, and has been with Diablo Valley Oncology Hematology Medical Group since 2008. Dr. Chen.
Thank you for all for coming here today on a beautiful Saturday afternoon. As Dr. Kramer and Dr. Strasnika talked about, in terms of the lung cancer statistics, in 2013, we expect about 228,000 new cases of lung cancer will be diagnosed. And it's pretty equally distributed between men and women, so about 110 to 118,000 in either men or women. There is an estimated about 159,000 deaths from lung cancer, and that accounts for about 27% of all cancer deaths. But we also have a lot of patients who are cured from lung cancer, and nationwide there are more than 380,000 lung cancer survivors. The lung cancer includes non-small cell lung cancer, which comprises about 85% of the lung cancer, and small cell lung cancer that comprises about 15% of the lung cancer. So a little bit about the anatomy of the lung, and Dr. Strasnika has gone over the staging with you. So an example of a stage 1 lung cancer would be a small lung mass that's involved in the lung only without extending into any of the lymph nodes. And an example of a stage 2 lung cancer would be cancer involving the lung as well as regional lymph nodes.
Could you pull the microphone in front of you just a little bit?
Is this better?
It's great.
Go back. And an example of the stage 3 lung cancer would be cancer involving both the lung as well as the lymph nodes, for example, in the middle of the chest area. And an example of a stage 4 lung cancer would be cancer involving the lung, perhaps the lymph nodes or other organs such as the liver, the bone, or fluid that's outside of the lung cavity. So we used to look at the lung cancer, categorize the lung cancer into how they look under a microscope. So a patient would come in after Dr. Strasnika has done the surgery, and they would have, for example, squamous cell lung cancer, or an adenocarcinoma, or large cell lung cancer, or there is not otherwise specified. And that's how we used to categorize lung cancer. The treatment of non-small cell lung cancer, which is the majority of the lung cancer, is a combination of surgery, with also potentially, chemotherapy or radiation, or newer agents such as targeted therapy that I will expand later. The treatment of small cell lung cancer, which is about 15% of the lung cancer, that comprises of either chemotherapy and radiation done together, if it's small, if it's comprised in the same radiation port, or mainly chemotherapy if it's spread outside of the lung area. Okay. So when is radiation used in lung cancer? It can be used as a primary treatment modality if the cancer cannot be removed by the surgery because of the location or the size, or if a patient's health is too poor for surgery, or if a patient does not want surgery. It can also be used after the surgery to kill any small deposits of cancer, or before surgery along with chemotherapy to shrink the tumor to make a surgery possible. It can also be used to relieve symptoms of advanced cancer, such as pain or bleeding. Okay. When is chemotherapy used? So it can be used either before surgery with or without radiation to shrink the cancer, which makes a surgery possible, and that's called neoadjuvant chemotherapy. It can also be used after surgery to kill cancer cells that potentially has been left behind. It is the main treatment for patients with advanced cancer, with a stage 4 cancer. So in the past, I would say probably about 6 years ago, when we have patients who are diagnosed with lung cancer, for example, when they're diagnosed with advanced lung cancer, we would treat them very similarly. So it could be, one patient who has had a smoking history for 30 years versus another patient who has never had any smoking history. When they are diagnosed with advanced lung cancer, we would offer them the same type of chemotherapy. But now we're learning that the patients are very different. They have their unique molecular profile. The cancers are very different. So instead of looking at all the patients and treat all of them the same, now we're looking at to see what are the differences within the cancer, and are we able to treat them differently and also more effectively, as well as having lesser toxicities. So we would separate out the patients, and there are patients, if we can identify specific mutations in the cancer, what we call driver mutation. And what that means is that that mutation drives the progression of the cancer, the growth of the cancer. We would offer them the specific targeted therapy. And in patients who we don't identify a driver mutation, then those are the patients we would offer them the standard treatment. And so what kind of mutations are we detecting in the cancer? Now that, so still a larger percentage of the patients, we don't detect a specific mutation. However, we are also seeing a significant amount of mutations that's detected. For example, the KRAS is detected in 22% of patients, and EGFR mutation is detected in about 17%. There's a type of mutation called EML-ALK mutation that's detected about 7%. And there are a lot of studies looking at a lot of other mutations. So how do we use that information? If we're able to identify a specific mutation, then we can offer them a more personalized medicine. So one example is this EGFR mutation. It's found in about 10 to 15% of all lung cancer patients. And in these patients, 85% of the patients would respond well to a drug that specifically targets that mutation. It's more commonly found in never smokers, patients with adenocarcinoma, in women or Asians, but it doesn't have to be that. We're also finding that not all EGFR mutations are the same, so there are more sensitivity mutations and there are more resistant mutations. In the past, there was in the United States, Tarceva has been the main drug that's been used for people who have advanced lung cancer who are EGFR mutation positive. And some of you may be aware that this year there was a new drug that was FDA approved for people with EGFR mutation, and that's the afatinib. The data came from a European trial where they compared in people who have advanced cancer, they compared treatment with the afatinib compared to chemotherapy. And what you see here is the blue arm is the afatinib and the red is chemotherapy. So you can see in people who have this particular mutation, this oral pill that people take once a day actually works a lot better than chemotherapy. So another example is a type of mutation called EML-ALK, which was the drug for that is called crizotinib. What happens is that when there's a fusion of the two, the EML and ALK, it becomes another driver mutation. It turns on the proliferation of the cancer. And there has been this nice timeline in terms of the development of this drug called crizotinib. It was initially found in 2005, but it took many years for people to realize that it actually works well in the subpopulation in lung cancer. And the picture here where you see this what we call waterfall plot was the original data that was presented. Above this baseline, below the baseline are all the patients that the cancer responded to the drug. And the ones that's going up, the above one, was the people that did not respond. So you can see if people harbor this mutation, most of them responded nicely to another oral drug. And this is an example of a 43-year-old gentleman who is a never smoker. He developed lung cancer, and you can see the lung cancer is a bright a spot there. And the top one is before he had treatment, bottom one is after just one cycle of the treatment. And you can see basically the cancer regressed or shrank very, very nicely. So I think that gives us a lot of hope. And so in terms of the treatment, at least for the people with advanced lung cancer, we are going to, our first thing to do is actually take a look at the molecular profile of the cancer and separate them out. In people, if we can identify a driver mutation, we're going to treat them with these specific targeted agents. And in people who we don't identify a driver mutation, then we would use standard therapy, but also realizing that in the future, it's likely that more and more driver mutations are going to be identified. Okay. So in the patients who we don't have a driver mutation, then there are also clinical trials looking at are there other things we can add to the traditional chemotherapy that makes the treatment more effective. One of the methods we use is a monoclonal antibody called bevacizumab, or known as Avastin. What Avastin is that it can be used to shrink the blood supply that feeds the cancer. So if we can shrink that blood supply, then hopefully the cancer will shrink. And the studies actually have demonstrated that. So there was a clinical trial that looked at chemotherapy alone compared to the chemotherapy plus the Avastin, and what they found was that the combination worked better in terms of shrinking the cancer as well as delay the onset or the progression of the cancer. Okay. There are also other ways that we're using that's different from 5 years ago in terms of keeping the cancer away or try to shrink the cancer for a longer period of time in people who have advanced cancer. One option we use is called maintenance therapy. That is in people who have advanced cancer after the initial course of the treatment, that is either 4 to 6 cycles of chemotherapy. Instead of stopping it, which was what we had previously used, now we're going to switch them to a single agent or a combination agent and continue with the treatment. And the data have shown that that keeps cancer away for a longer period of time. There is also a very new a drug that's under development, and a lot of people have asked me about this, and it's called anti-PD-1, and it's called programmed cell death protein. The way that works is that this particular anti-PD-1, which is a very well tolerated antibody, it actually can help us with boosting our immune system to fight the cancer. So the toxicity of that is actually quite very tolerable, not a lot of toxicities. But in a lot of patients, actually in people who have squamous cell cancer, in people who have smokers, the early clinical trials have demonstrated amazing results. So at our group, we actually just started a clinical trial with the anti-PD-1 as well, and we're very excited about that. Both UCSF and Stanford have the clinical trial. So certainly there are a lot of side effects, for chemotherapy, including potential hair loss or mouth sores, loss of appetite, nausea, diarrhea, constipation, increased risk for infection, fatigue, or neuropathy. After the completion of treatment, for example, stages in people who have stage 2 or stage 3 who have completed surgery and followed by either chemotherapy or chemotherapy and radiation, it is still very, very important to go to follow-up appointments, which includes physical examination, laboratory testing, or imaging testings. Usually we do recommend CT scan every 6 to 12 months for the first 2 years after the treatment is completed for early stage lung cancer, as well as yearly CT after that. And also we encourage people to have a very healthy lifestyle, stay away from the tobacco, eat healthy, as well as being active, and those are all important in terms of continuing boosting our immune system and trying to fight the cancer. So my vision for the future of cancer treatment would be that at some point we're going to know the molecular sequence, of the cancer, and then we can take the sequence and go to the doctor and say, this is my sequence, give me the drug that's specific for that. We're not quite there yet, but I think there are a lot of advances and a lot of hopes for that. Thank you.